to have friends and colleagues on board. We'll see what you think. This is really a lot of my thoughts and some of the research I've done over the past 10 or 15 years. It's not about genetics, which is what I'm most well known for, but it's some of the ideas around what do we really think about breast cancer, how much do we know, and have we got it right, or should we be thinking a different direction? So starting off, this is what I teach my students in graduate school in epidemiology. If you see something surprising in a study, you got to consider the following four consists. One, you screwed up the methodology. Two, you misinterpreted the results. Three, it's a chance finding. And four, it's true. But you've got to rule out the first three before you can come to the conclusion that four that you're finding is true. So this is every slide, every breast cancer talk will start with the same slide. And this is no exception. So we think of invasive breast cancer as a progression from a normal epithelial duct, ductal lobular unit, through to atypical hyperplasia, then to DCIS, ductal carcinoma in situ. Then when those cells break through the basement membrane, they become microinvasion. And then when they break free and invade the duct and are invade the stroma, greater than 1 millimeter in focus, that would be called invasive ductal carcinoma. This is pretty much how we've been thinking about breast cancer for the past 40, 50 years. But there's a study surprisingly came out. You might have heard of this study, the COMET study with Shelley Wang and them, where they were asking about can we be offering active surveillance, a watch and wait approach to DCIS. So they randomized half the patients with low-grade DCIS to active monitoring, which was waiting to see if they progressed or if the DCIS grew or if they got an invasive component. And half of them, they took out the DCIS at diagnosis. So half got surgery initially and half waited to get surgery until they had a progression. Well, what they had in the first 2 years was that active monitoring actually had a lower risk of invasive cancer. That's surprising. So the COMET study, after 2 years of follow-up, which is a short time, for those women who underwent surgery, the 2-year risk of invasive cancer was 8.7%. But these are randomized. 427 women underwent watchful waiting. This isn't randomization, this is actual treatment. The risk of invasive cancer is 3.1%. Now that's very surprising. They called that a positive result in the sense that you could de-escalate, in the sense that you could do watchful waiting. You didn't need to do surgery up front, and it didn't impair the benefit of the patient. But that was a kind of a conclusion a medical oncologist and a surgeon would make to come up with a positive result. The real answer is completely opposite. Resecting DCIS did not prevent invasive cancer. So what are we all about? Well, that's true. This has got to be wrong. If this is true, then resecting the DCIS should prevent this, but it didn't. In fact, it was higher in the people who were watching wait. They had more invasive cancers if they left the DCIS in place. And that really raises sort of a fundamental question of how we got it wrong. So let's jump back. We got to jump back a couple of years. Me and Vasily looked at this. Why do women in one breast cancer in one breast get a bilateral mastectomy? Many think it's going to save their lives. Well, they want to ask, what's the risk of contralateral breast cancer? Does contralateral breast cancer impact on mortality? Does contralateral mastectomy prevent contralateral breast cancer? And finally, does contralateral breast cancer prevent death? So these are the questions we raise. Well, what's the risk of contralateral breast cancer? Well, we looked at this, me and Vasily David Lim. The risk was 0.4% a year, pretty well consistent, or 4% over, or 10% over 25 years. So the risk of getting a contralateral breast cancer is 10% in 25 years. What about the Simon? And it was the same whether, this is amazing. The risk of contralateral breast cancer is steady. It's 0.4% a year, never levels off. And it's the same for DCIS patients as it is for invasive breast cancer patients. But does contralateral breast cancer impact on mortality? Let me get rid of this. Oops. Yes, if you got a contralateral breast cancer, your risk of dying jumped from 11% to 18.4%. So yeah, contralateral breast cancer impacts on mortality. In fact, the hazard ratio is 4 after getting a contralateral breast cancer. So clearly, contralateral breast cancer increases the risk of death. This was based on a very large study. It's here. I can't. So does contralateral breast cancer, I can't see the top of this. Let me get rid of it. Nice. Okay. Yeah, I have to get rid of the thing on the top.
What is it, the audience?
All these bars are, okay, there it goes. Does contralateral breast cancer mastectomy prevent contralateral breast cancer? Yes. In the match group of 7,142 women, 204 got a contralateral breast cancer after unilateral surgery versus 15. So it reduced it dramatically from 2.9% to 2%. Does contralateral breast cancer mastectomy save lives? Well, we reduced the risk of breast cancer, but there was the same number of deaths. Exactly the same number of deaths. Well, two different. 557 versus 559. So we prevented 189 contralateral breast cancers, but only prevented 2 deaths. So it didn't prevent death. Now that was considered, that paper was published in JAMA Oncology in 2024. There was a lot of response to it, thinking, well, we must have screwed up the methodology or the interpretation. But let's think about that. Well, maybe the methods are wrong, but we did a very elaborate propensity matching of the 2 groups. Some people say, well, the reason they didn't kill you is because they were caught early by screening, but the death rate was 4 times higher after contralateral breast cancer, so that can't be true. Some people say, well, it could be due to chance. Well, maybe, but we did 7,000 bilateral mastectomies and couldn't show an effect, so that's unlikely. And some people say, well, they were metastatic. They were not a new primary, they were metastases. But that's unlikely because the risk of contralateral breast cancer is the same for DCS patients as it is for invasive cancer patients. So they're unlikely to be metastatic. So I conclude that they don't metastasize, that a contralateral breast cancer is not a potential for source to metastasize, rather it's a marker of an aggressive cancer from the outset. That those people who have aggressive cancers that are likely to kill you are more likely to develop a contralateral breast cancer. But that contralateral breast cancer doesn't impact on the survival. It's the underlying propensity of the cancer at first. Yeah, so they say it's a complex conundrum. Steve McCon wrote an article, but very less saying, well, maybe we didn't do all the right adjust for the confounders. And that was JAMA Oncology. That was September 2024. But that causes us to think. Or as Neil Bohr said, how wonderful, we have a paradox. We can have hope of making progress. So just an aside, we looked at the same thing in our hereditary breast cancer database, and those women who were treated with contralateral bilateral mastectomy had the same survival as those that were treated with lumpectomy. Ones that had a mastectomy did worse. But that suggests the same thing actually holds true for contralateral mastectomy in BRCA1 carriers, even though the general consensus is it's an effective way of saving lives. Okay, so let's go back. So this is a paper we published back in the day when it was 2007 with Rebecca Dent, and you can see several of our colleagues are on this. This is actually the most highly cited breast cancer paper ever coming from Canada. Cited 4,800 times, 4,800 citations. Most cited paper for triple-negative breast cancer. And that's interesting because that was in 2007. We're going to come back to that. So this year, now we wrote this in 2007. These are patients diagnosed at Women's College Hospital from 1987 to 1997. I went back and looked at them this year, 30 years later. So let's update that study, 2025. Now we're looking at ER-positive breast cancers. Forget the triple-negative ones for now. These are ER-positive diagnosed from 86 to 2000, followed from 2020, treated at Women's College Hospital, and 381 of those 149 women died of breast cancer. And here's the annual mortality rate for 25 years. It started off a bit low, then it hits 2% a year, hits 2% a year, stays at 2% a year for 25 years. So the chance of dying in year 25 is 20.3%, which is the same as the chance of dying roughly in year 8 or year 5. The chance of dying of ER-positive breast cancer stays the same, seems to never go away. And these women 25 years out are still facing we're updating this with the Ontario Cancer Registry. But it's pretty surprising, pretty shocking that if you continue for 25 years, the mortality rate stays the same. And it more or less stayed the same over all the age groups. There was a more likely to die under age 50, but between age 50 and 80, the annual risk of dying over 30 years was 2% a year. And if we look at that, so we split it. So this is the first, I don't know if you can see the top. If you can see the first 10 years, this is the first 10 years of follow-up. You can see what predicts mortality, age of diagnosis, size, lymph nodes, HER2, tamoxifen was preventive, tumor grade was a risk factor, chemotherapy possibly. So that's the first 10 years. What about year 10 to 25? Well, let's look at that. So overall, we can look, this is under 40 and over 40, which is a big dramatic difference at diagnosis. But you can see for 25 years, the risk of cancer is not going away. Perhaps if they lived for 100 years, they would all die of breast cancer. Now, this is pretty shocking. The extent, 57% survival at 25 years. And they continue to die in 2025 at the same rate they did in 2000. Now, I can see everybody's going to say, well, that's not surprising, but now we have better treatments. Since that year, we've introduced aromatase inhibitors, we've introduced GnRH agonists, we've introduced CDK4/6 inhibitors, ribociclib and abemaciclib, we've introduced fulvestrant and SERDs. So we'd have a much better thing now. But that's a good point, but you're also missing the point. These were treated in 2000, but they're dying in 2025. In other words, if we've got all these great treatments for ER-positive breast cancer, why aren't we reintroducing them into this cohort who continue to die at the same rate they did 25 years ago? In other words, should we be thinking about reintegrating clinical care for people who are ER-positive survivors, even up to 25 years after diagnosis? Well, the argument against that is what has never been really shown to be seen. The CALOR trial didn't have any benefit for ER-positive studies. But I asked you the question, is there anything we can do for patients who are alive in 15 years or 20 years out of diagnosis with ER-positive breast cancer? Now they say, well, we should extend the estrogen the tamoxifen for 10 years. May be true. So what predicted survival from year 10 to 25? Surprisingly, size was still the strongest predictor. This is survival from year 10 to 25. Size was strongly predictive, and nodes were strongly predictive, but nothing else was. So if we look at the survival from year 10 to 25, interestingly, the age went away. The size stayed there, the node stayed there, the HER2 went away, the chemo went away, tamoxifen went away, the radiotherapy went away, the surgery went away, the tumor grade went away. So the characteristics of breast cancers, they're the same breast cancers, but the predictors of survival, which we always use 10-year survival as our outcome, is really not sufficient for ER-positive breast cancer. Those factors, the only thing that predicts survival after 10 years are size and nose, which are intrinsic. Now, here's one that really drives me. This local recurrence, local invasive recurrence, was a huge predictor. So this is local invasive recurrence at any time in the 25 years. Anyone that got it, the survival rate from 10 to 20%, 25 was only 41%. But we treat local recurrence for ER-positive breast cancer locally. Generally, we reevaluate, we do surgery, we do radiotherapy. It's controversial, and some give chemotherapy or hormonal therapy, but most don't. Generally, the CALOR trial, which was the main trial of a few hundred, 600 people, I think, with invasive ipsilateral recurrence after ER-positive breast cancer, showed no improvement introducing chemotherapy. I don't know about hormonal therapy, but one would think it certainly would be a challenge that if a woman has a local recurrence and faces a 25-year survival rate of 41%, that we should do nothing. I don't know. I mean, I'm not suggesting we're doing it wrong. I'm suggesting this is something I think we should take really more consideration. So the conclusion of this part of the talk is ER-positive cancers reoccur at a constant rate. The rate doesn't diminish after 20 years. If you wait long enough, theoretically, all will succumb. Which leads me to the conclusion, going back to the first slide, that the dormancy, the tumors, the possibility of cancer is there at dormancy, metastatic, occult metastases are there from every cancer at the time of diagnosis. And if we go from age 25 to 10 to 25, that the treatment doesn't cure patients, but probably prolongs the tumor dormancy. We'll get back to that. Now, this is interesting because this is a very important paper, probably the most important paper came out in breast cancer treatment last year, Angela Luchodosh, I think in Chicago. And they actually looked at tumor dormancy in the sense of minimal residual disease was bone marrow positive cancers. And they found that if they did a bone marrow biopsy and found dormant cells in the bone marrow, that they could actually improve the survival by giving them mTOR and rapamycin, or I think the other one that was hydrochloroquine. I hope you read this paper. This is a really important paper. So they say, based on that they can predict survival based on the bone marrow. But unlike ctDNA, using dormant tumor cells in the bone marrow, they can actually reduce the mortality rate by introducing chemotherapy when they had a positive bone marrow biopsy. And they said that a proportion of women with ER-positive breast cancers will have disseminated tumor cells at the time of diagnosis and eventually metastatic colonization outgrowth. I agree with that, except they say it's a proportion. I say it's all of them. Because if you wait long enough, as far as I can tell, they'll all recur. So I would agree with them, but we have to think maybe it's everybody jumping. Okay, so we talked about a few things. Let's talk about ipsilateral recurrence prevent death. Well, we know this from Veronese and Bernard Fisher back in the 80s that preventing ipsilateral recurrence post-breast cancer doesn't prevent death. And we got that from Bernie Fisher from NACB1. I can't remember which one this is. B4, that treating people with total mastectomy and compared to radical mastectomy, total mastectomy with radiation, didn't improve survival. Removing the tumors nodes didn't improve survival. The radiation didn't improve survival, and the mastectomy versus radical mastectomy was the same. And then they went on to show that lumpectomy versus mastectomy was the same, of course. They say the risk of distant disease, and I said this, was 3.4 times greater in patients when an ipsilateral recurrence occurred. So the ipsilateral recurrence, the risk of distant disease, increased 3.4 times. However, neither mastectomy nor breast radiation lowered the risk of distant disease. They concluded in 1991 that an ipsilateral recurrence was a marker for a risk already present indicative of a failure of adjuvant chemotherapy to eradicate latent metastases. We concluded in 2024 that a contralateral recurrence was a marker for a risk already present and indicative of a failure to have therapy to eradicate latent metastases. So going back, jumping back just to hark on this a bit, if we remember the updated 10 to 25 years, we saw a huge impact of death when they got a local recurrence, right? The risk of death went from the survival went from 75% to 48% after a local recurrence, but the mastectomy had no benefit over the lumpectomy, basically solidifying what Fisher and Veronese would have said. So let's ask, so you consider that it doesn't the local recurrence doesn't metastasize, the contralateral breast cancer doesn't metastasize. Does the breast cancer metastasize? Well, we don't have that direct evidence. But if you think of an invasive breast cancer following DCS as a primary cancer, we can address this in a sort of a roundabout way. And we Vesprini did this. If you go back to the old story that DCS is a precursor to invasive cancer, it can't metastasize, but the invasive recurrence following DCS is a primary breast cancer, what we've all come to believe, then that's it can metastasize. So we asked, what's the risk of local invasive recurrence after DCS? Does a local recurrence after DCS invasive recurrence increase mortality? And does preventing it reduce death? I'm jumping a little fast. And we showed with torisopic, in other words, that the risk of invasive recurrence after DCS was 15.6%. It was the same for DCS stage 1 and stage 2. This is the risk of local invasive recurrence in the ipsilateral breast in the 15-year period following DCS stage 1 and 2 breast cancer, and it's fixed. This is women's college patients. And then we did a SEER database study, matched 29,000 women, lumpectomy to mastectomy. We got 240 local recurrences in mastectomy, 1,162. So the mastectomy greatly reduced the risk of local invasive recurrence, but had no impact on deaths. In fact, the majority of people that died of DCS had no invasive recurrence. They went from DCS to invasive recurrence. So we prevented 922 invasive cancers, but didn't prevent any deaths, which raises the question, which you guys are going to hate, does the invasive recurrence have the potential to metastasize? I think not. So preventing ipsilateral recurrence after DCS doesn't prevent death. Therefore, the death is due to metastases of the DCS or a precursor. I used to think my first conclusion was that DCS could metastasize. Now I have revised that, thinking that, in fact, it's just another manifestation of a risk of an underlying breast cancer. And I don't know what that breast cancer looks like, but it's the metastatic cells occur at the time of diagnosis, whether it's a diagnosis of DCS or invasive cancer. They're already present. So let's just review that. The manifestations of breast cancer can be ipsilateral breast cancer, ipsilateral recurrence following a breast cancer, contralateral breast cancer. All three manifestations of breast cancer are what we like to think of as breast cancer. We like to think of this as what we're treating. We like to think of this as a source of metastases, but in fact, all three of them are in the same boat and none of them has the potential to metastasize. Now that's interesting. Well, it's interesting, but it's also kind of shocking. So we recommend annual mammography screening after breast cancer. Why do we? Everybody does it, right? Everybody on this audience does it. We recommend screening for breast cancer with mammography after breast cancer to find recurrence early, to find contralateral cancer. The goal is to reduce mortality. But if I can prevent the cancers with surgery completely without benefiting any mortality, so why would preventing cancer is not effective? Preventing it surgically has no impact on mortality. How can screening be any better? Well, I think the real answer is screening is not done to reduce mortality. Screening is done to make the patients happy. And there's nothing wrong with that. There's nothing wrong with saying to a patient, we did a screen on you, you got no evidence of a contralateral cancer, you got no evidence of an ipsilateral recurrence, therefore you have a lower chance of dying. And the woman goes away happy. 99% of the women will be told you're okay. and they will leave the office happy to have undergone that screening. But there's no study out there. If anybody can find a study that shows that screening for contralateral cancer, hepatocellular cancer, recurrence prevents mortality, I'd be glad to revise my thoughts. I think Ellen and I wrote a paper on screening for contralateral breast cancer one time. Well, if screening for recurrence doesn't work, how does screening for breast cancer in the first place work? Now, this is controversial, but, let's go on. So we wrote this paper in 2014, me and Tony Miller. 30 years. Tony Miller was my mentor, and we started working together in 1984 with the research. Then we did the Canadian breast cancer study, randomized 90,000 women to breast cancer screening for 5 years, and the other ones just physical examination once. And lo and behold, we didn't see a benefit. This is 30 years following. The number of deaths in both arms was the same. This was heavily criticized. This is like, been just thrown a bucket over. This has been heavily criticized by people all over the world. We screwed up the methodology and we screwed up the interpretation. But I don't think we did. Why? How did we screw it up? Well, they said women with palpable masses, they went to the doctor, the nurse felt a mass. If they had a palpable mass, they were switched to the mammography group, so they compromised the randomization. You hear this over and over again, except the data's on my computer, not theirs. And when I look at it, there was 270 women in the control group had a palpable mass, and 274 women in the mammography group had a palpable mass that diagnosed that first screen. And I took them out. So I said, okay, fine. I'll take those people out of the study. I took out the people with I took out the people who were diagnosed with palpable breast cancers in year one. Nobody switched arm after year one. And we had exactly the same number of deaths in both, almost exactly the same number of deaths in both groups. I stand by this. Nobody else does, because they just can't stand the conclusion that it doesn't work. I think we're drawing to this is a matter of debate. So, question, does breast cancer metastasize? Or what we're seeing is a reawakening of dormant cells present at diagnosis, similar to the Michele paper, which said these dormant cells in the bone marrow can reawaken and present distant metastases later. So let's talk about tumor dormancy. Go back. So this is a very famous study. Talked about it, which showed triple negative breast cancers on the top and positive breast cancers on the bottom, positive recurrence. This was the most cited paper from Canada. Trouble is, we got it wrong. It's not because they're triple negative and they're ER negative. It's an intrinsic principle of breast cancer that the lower the risk of recurrence, the longer the time to death, and the more prolonged the time to death. And we did that. Me and Vasily did this, a theoretical paper, which was very interesting, looking at the time to death of all breast cancers can be determined purely by the tumor dormancy period. So what we did, this is a bit complicated. So we took all the data in SEER, divided into 10 quintiles based on the risk of dying at year 20. So we took all the cases, divided them by into 10 quintiles, equal size the risk of dying at year 20. And we can see this looks very similar to that data we saw for triple negative versus ER positive. The ER positives, the low risk ones, are dying at a continuous rate. But then we did a model. This is a very simple model. We took all the data in the SEER, and we only created one variable called the probability of reactivation in a given year. So we created a variable, which we call alpha, which says at any given cancer, there's a probability of reactivation of 0.1 to 1 or whatever. And we applied that for the breast cancers for the 25 years. And that's all we did, and we got exactly the same data, which suggests that it's possible. I'm not saying it's true. I'm just saying it's possible to explain the risk of dying of breast cancer purely on a single factor, which is the probability of tumor dormancy reactivation. Because the simulated data looks exactly like the actual data. maybe it's not true, but it's certainly a question is raised. So we look at, so I think of tumor dormancy. I'm not the only one. Christoph Klein and others have looked at this a lot, and others are thinking that the way dormant cells are reactivated is poorly understood, but it's certainly a critical question. So let's go to the third thing, what I call the switch, going back. Now, this is the data on this is the most interesting thing. This is the data on contralateral breast cancer. So what we have on the bottom is the risk of breast cancer in the first breast is here, I believe, by age per 100% per year. So the risk goes from less than 0.1%, way less, 0.01% at age 30, to about 0.2% or 200 per 100,000 per year. And you can see the risk of breast cancer climbs till about age 65, and then it flattens out at about 200 per 100,000 per year. That's the risk of getting cancer in the first breast. On the top is the risk of getting cancer in the second breast once you've got cancer in the first breast. And two things about it, it's flat. It doesn't really increase, maybe a little bit. It starts off at 400 per 100,000 per year and goes to 400 per 100,000 per year, dips a little at age 55. So the risk of the first breast cancer increases with age. The risk of the contralateral breast cancer doesn't increase with age. It's flat. It's fixed at 400 per 100,000 per year. So at age 30, the risk of breast cancer, let's say at age 40, the risk of breast cancer is 80 per 100,000 per year. And the risk of contralateral breast cancer is 300 per 100,000 per year. So let's think of 40-year-old women. She's got breast cancer in the right breast. Now, her risk of breast cancer in the left breast is now 0.4% a year. What was it a month ago? 400 per 100,000 per year or 50 per 100,000 per year? Well, one would have to think parsimoniously, the parsimonious and the most elegant explanation is the risk in both breasts is symmetrical. So a month before, her risk of breast cancer was 400 per 1,000 per year in both breasts. It's unlikely that once she gets one breast cancer, the day after, her risk goes to 400 per 100,000 per year. I think the risk is symmetrical, which means that if she had the same risk, high risk, she was a high-risk person, that women go from low risk to high risk as a switch. At any given time, the risk of breast cancer in both breasts is the same, which I assume. So the switch from 550 to 400. The switch happens before the breast cancer. And I wasn't the first one to think of this. Will Fowkes pointed out to me that Doug Easton wrote this editorial in 2000 based on looking at genetics, that women with breast cancer have a high constant risk of breast cancer in the opposite breast. A new hypothesis to explain this observation is that a woman's risk of breast cancer starts from a genetically determined age, and the switch occurs at a genetically determined age. What causes the switch? I don't know. So, wrapping things up, I don't know what time it is. Cancer metastases, I would say, occur in very few cells, probably with stem-like properties. We don't know what they look like. We see what we see under the microscope is when we biopsy the breast cancer and look at it histologically. Now we have molecular markers, we have Oncotype DX, we have genomic markers, but the metastases, if they're going to metastasize, are present at diagnosis. We don't know what they look like. They probably are cells with low proliferation rate, and they activate at a period of dormancy. This spread of the breast cancer cells occurs after a switch which is inherent. Some women go for a switch early, some women don't go for a switch. These cancer cells are adapted to enter the metastatic niche. They probably are spindle-like cells which reactivate to form visible cancer deposits. Clinical implications. Local control doesn't affect mortality. We've known that. We've known that for ipsilateral breast cancer recurrence for 30 years. But now I would like to extend that to contralateral breast cancer and invasive breast cancer following DCIS. So in each case, invasive cancer following DCIS, contralateral breast cancer, ipsilateral recurrence, Local control does not affect mortality. There is some benefit from radiotherapy we've seen, Danny showed, but I don't think it's due to local control. I think it's due to something working in the underlying in the metastatic niche. I would conclude, and this is certainly controversial and would be happy to be proven otherwise, that early detection does not appear to help because those cancer cells are present already at the time of diagnosis. I think it's really important if we can find the biological basis of the switch, which makes a woman go from a low risk, essentially from 0 to 400 per 100,000 per year in both breasts. This cancer susceptibility may switch on early in life or it may switch on later in life. But at this point, both breasts become predisposed to develop breast cancer. Which leads me to the sort of the conclusion, I think, of a different model of breast cancer rather than this sequential model that we see in the DCS to progression. I think we have a model, a parallel model, and I'm not the only one to support this, that you go from birth to a genetically predetermined switch. At some time you switch on and you go from a low risk of breast cancer to risk of 400 per 100,000 per year in both breasts. These early cells occur in the breast. What they look like, I don't know. I propose they're not easy to find because no one's found them yet. But these early cells in the breast can go to the lymph nodes, can go to produce breast cancer in the breast, the left breast, local recurrence. They can go to produce breast cancer in the bones, the liver, the lung, and the brain. But these metastatic niches have reactivated lead to the death from breast cancer. These are markers of the aggressivity of this. But I don't have an arrow going from here to here. I don't have an arrow going from here to here. The arrows go directly to here. And one would also could remark what makes this common sense is if you think about lymph nodes, we all think about lymph nodes, and it's interesting that the breast goes to the lymph nodes and from the lymph nodes goes to metastasize. But Fisher showed that removing lymph nodes didn't improve survival. But the other thing I think which people don't really acknowledge well is that lymph nodes are diagnosed at the time of breast cancer, and that's why they're so predictive of mortality. It's extremely rare. It only happens in 2% of patients that a person goes from lymph node negative to lymph node positive after the cancer is diagnosed. So in fact, the lymph nodes become positive before the breast cancer becomes apparent. Otherwise, we would see, whereas bone, lung, brain, liver, only 4% of breast cancer patients present with stage 4 breast cancer with apparent cancer in these sites at the time of diagnosis, whereas 25% of breast cancer patients will develop them after the breast cancer is diagnosed. So these happen after and these happen before, but they all happen as a manifestation of these early disseminated cancer cells. It's just the time to appearance by current imaging takes longer. So Christoph Klein proposed a parallel model. I don't want to take credit for it. Two basic models. The prevailing archetype places the engine of cancer progression within the primary tumor before metastatic dissemination. The second position parallel independent progression of metastases arising from early disseminated tumor cells. So I'm not the only one who's come to the same conclusion. And I borrowed this from Christoph. Cells from early low-density lesions displayed more stemless features, migrated more, and founded more metastases than cells from dense advanced tumors. So going forward, I mean, I've sort of set back a lot of how can we go forward? I think if we could really identify the cells that underlying early metastases, we could possibly consider early chemotherapy, possibly a vaccine. It would be nice if we could understand the molecular basis of a switch, studying healthy breast tissue before they get cancer, perhaps studying the contralateral breast tissue of a woman with breast cancer without any clear manifestation of breast cancer in the other breast. Presumably, there's something in the other breast which has already changed, which suggests it has a risk of 400 per 100,000 per year. And I think we should really focus on tumor dormancy. Now, I'm not saying tumor dormancy is the only factor, but I think it looks like a very strong factor. And that is, in the model that Vasily and I proposed, the reactivation was from tumor dormancy to active cancer cells. was entirely probabilistic, was entirely stochastic, and it was fixed over time. Perhaps we're wrong. Hopefully, we were wrong, and there are actually factors in the patient, either in the microenvironment, in the tumor itself, or in host factors, which activate dormant cells become activated. And if we could identify those factors, perhaps they could be reversed. From which we started a study to look at tumor dormancy, taking 10,000. This is still kind of in its infancy. We have a lot of work to do to identify 10,000 women with ER-positive breast cancers within 20 years of diagnosis that haven't had a local invasive recurrence or a distant recurrence, and provide an annual questionnaire asking them about their lifestyle, asking about medical hospitalizations, drugs, etc., to see if we can actually find risk factors which go from predict distant recurrence after ER-positive breast cancer. I think I probably went a bit fast, but hopefully I have time. I'd like to thank my colleagues, Vasily Zinakea, Tori Sopuk, who really worked with a lot on this, David Lim, the surgeon with our group, Ping Sun, the statistician who crunched the numbers, and now looking back to Bernard Fisher, who came up with this idea of parallel model back in the 1980s, and to Christoph Klein, whose readings have really progressed in terms of looking at the molecular basis for the parallel model. And last but not least, just to plug, I have two books. All the work I've summarized here is in the book A Fair Trial, published last year. Anybody interested, it's goes in depth to what I talked about today, about what we really might challenge about our thinking about the foundations of breast cancer. And our next book with Cassius, I don't know if Cassius on the line, we wrote for patients, which is coming out in August, 10 questions to ask my doctor about breast cancer, which is designed for patients who newly diagnosed with breast cancer in order to try and address some of the questions that they should be interested in discussing further and going with their doctors. And I'll thank you guys. And we actually have time for questions if there are any.
Yep. Yeah, no, that's really great, Stephen. It's always a pleasure to hear your thoughts and your decades of experience and decades of data. If people have questions, they can unmute, or they can, if they're shy, they can send in the chat. I guess I just have a couple of questions based on kind of your theory, like one being that early detection doesn't save lives. Do you think early detection prolongs life? You know, because anecdotally, we all see patients that get diagnosed with relatively early disease and unfortunately decline treatment, and they seem to progress relatively quickly, and presumably if they've been treated, they would not have.
Yeah, well, those are the great. That's the experiment that has been done. Well,
Sorry, Neil, can you mute yourself for that?
Yeah, we haven't done that. I mean, you're talking about an observational study, and if that were could be done if you could even collect that, if someone had enough data on people who declined treatment compared to people who took treatment, and we could, match them to be similar characteristics, that would be a pretty important study. I don't know if it's ever been done. I don't know if it's feasible. You said we've all seen patients. Where would one go to find patients who decline treatment and to follow them in a systematic way? Certainly, early detection prolongs life in the sense that, I mean, even in our breast cancer screening study, those women, let's get this clear, those women whose breast cancers were detected by mammography lived longer than the patients who weren't. But we attribute that to lead time bias. And secondly, mammographic detected cancers have a very low progression rate. If we looked at mammogram detected cancers and we adjusted for size, we took two cancers the same, both were 2 centimeters, one was detected by mammogram, one was not. The ones detected by mammogram lived way longer. So mammography detectability is a positive prognostic factor, independent of size, nodes, and grade.
Ellen, you have a question?
Yeah, thanks for a fascinating talk, Stephen. So I'm just curious, BRCA mutation carriers seem to benefit both from screening and from prophylactic mastectomies. So how do you explain that?
That's a great question. I want to avoid it. We did show in a study on the MRI that the MRI detection of BRCA1 carriers was very beneficial, significant for survival. You're right. In the same study, we didn't see any benefit from mammography versus no mammography. And you and I have looked at MRI and BRCA1 carriers and have seen a similar thing. It could be different. I mean, the general number of carriers in the general population of breast cancer would be too small to skew the data. The carriers could be different from the non-carriers. MRI could be more effective than mammography. And I don't think there's been a randomized trial of MRI versus mammography in the non-carrier population. There's certainly been observational studies. And long shot, it's the what is the stuff you give them in the veins? It's the treatment with, it's the injection of the what do you call it? But I think that's a really important question. I don't think we screwed up those studies. I wrote the paper on the randomized trial and in the non-carriers and the randomized, the non-randomized trial in the carriers. I think the methodology of the randomized trial is superior to that of the observational studies, but I stand by both. I stand by both. How does prophylactic mastectomy work? Yeah, the cancer cells that become cancer do originate in the breast. And if you can remove them before they become activated and spread, I think that's possible. And that's why prophylactic mastectomy works. I mean, I will say prophylactic mastectomy works with BRCA1 carriers, but preventive bilateral mastectomy after treatment does not. So it's a controversy there, needs more work. I'd appreciate your thoughts.
I don't know. I gotta think about this. I'll get back to you, but thank you.
Any other questions from the group or in the chat?
Come on, guys.
So I guess then you're suggesting that you actually could prophylactically remove a breast before a breast cancer. Those people would all never die of breast cancer.
In theory,
but if they prophylactically and they found an incidental cancer, that's too late.
That would be my conclusion as well. That the removal of both breasts after cancer is detected doesn't prolong survival, but before it does. And we don't. These are just theoretical observations based on observational epidemiological studies. I don't know what those cancer cells look like. I don't know where they are. I don't know if they're in the bone marrow. I don't know to what. I mean, we've got a lot of confusion going on about cancer stem cells. We have disseminated cancer cells. We have ctDNA. We have circulating tumor cells. We have minimal residual disease. And no one's really picked up what all the relationships are. In other words, that in a Shelley paper showed if you find disseminated tumor cells in the bone marrow, you can improve the patient's survival by treating them. But no one showed that ctDNA, which is the strongest predictor of mortality in breast cancer, if you have ctDNA in the blood after chemotherapy is given, it's almost 100% predictive of mortality. No one has yet shown that if you intervene with chemotherapy, at the time ctDNA is detected, that I can improve survival. But if we do have a couple of minutes, I would like, comment on what we were talking about earlier, which is quite interesting about the use of invasive disease-free survival as an endpoint. Because we've all accepted, both the Natalie trial and a lot of trials, that we can use invasive disease-free survival as a surrogate endpoint for overall survival for breast cancer for the purpose of approving drugs. You guys probably accept that, right? And I thought that made sense. And there was a recent paper, Joyce O'Shaughnessy showed that there's a correlation of 0.82 between invasive disease-free survival and overall survival. And based on the correlation, strong correlation between invasive survival, disease-free survival, and overall survival, that it's a valid surrogate endpoint. But if we look back at our data on bilateral mastectomy, we see that a contralateral breast cancer and invasive cancer in the same breast, which are endpoints in invasive disease-free survival, are prevented by bilateral mastectomy. And if you get those, you get a high increased risk. So there's a strong correlation between invasive disease-free survival and overall survival when you look at patients with bilateral mastectomy or unilateral lumpectomy. But there's no benefit to the intervention. So even though a bilateral mastectomy will decrease invasive disease-free survival by 50%. I'll say that again. A bilateral mastectomy will decrease invasive disease-free survival by 50% because it eliminates almost contralateral breast cancers and ipsilateral breast cancers, but has no impact on overall survival. I just thought this. I wrote this yesterday. Came in and just wrote it up yesterday and sent it to a journal. But I think that really shows that it's erroneous to make the assumption that invasive disease-free survival is a surrogate for distant survival and can be used to validate systemic therapies. Having said that, I mean, local therapies and systemic therapies may be different, but bilateral mastectomy decreases invasive disease-free survival by 50% and has no impact on overall survival.
There's one question from Neil. Is there evidence of a switch to activate dormant cancers in other malignancies? His experience is that with melanoma, which is
I would have said melanoma. If I was younger, I'd study melanoma because I think it's got, the cancers that are brought up in this context, there's 4, are melanoma, prostate, renal cancer, and breast. I think those cancers have an interesting characteristic in terms of the nature of metastases. We've studied prostate cancer, but melanoma, you get these very weird things. For example, and I've asked this, I don't know if this has been done. The strongest risk factor for melanoma by a mile is previous melanoma. So you get a melanoma on your left arm at age 30, chance of getting a melanoma on your right leg at age 50 goes up 12 to 20 times. But are those the same? Are those different cancers? Has anybody ever actually looked at them genealogically to see if they have a genealogical common origin? But melanoma, also the tumor dormancy thing goes on forever. It can occur years after. You can't really predict what could happen, and it seems to be relatively constant. There's also, melanoma is the most common thing you get. One of them in terms of organ transplant and immunosuppression. But that's an interesting one. What was it? Be more specific with the question about dormancy? Yeah, I don't.
Yeah, just
These are, sorry, I get feedback here.
just whether other cancers, have evidence of a switch to activate dormant cancers from dormant. Yeah, melanoma is the one.
I think if you looked at the epidemiology of melanoma, it would be kind of interesting to see how, if the risk of melanoma associated with the age of person, the time from the first one, for people with multiple melanomas. I don't know how easy it is to get a bunch of people with multiple melanomas, but to see the nature of the recurrence and the second primary. And does the second primary impact on the survival, to what extent? That, these are the studies I think would be, if someone wanted to do it, I'd love to help. I don't have the database.
All right, I think that's all the questions. Thank you, Stephen. It was a great, thought-provoking talk, and appreciate it, and look forward to.
Yeah, maybe I thought it would go overtime. It actually was undertime.
That was good.
Too fast.
You nailed it. Okay, everybody. Thanks for showing up. Hope you enjoyed it.
Thanks, Danny. Thanks, everybody.
Bye, Stephen.